A medially directed coil at the renal end of the DJ stent, does it indicate extrarenal stent placement? Double J stent is a common urological procedure. Commonly, we place it for management of obstructive uropathy secondary to intrinsic or extrinsic ureteric obstructions. In emergency, they will be used for treatment of obstruction related to infection or stones. It will also be used post-embryological procedures like ureteroscopy or percutaneous nephrolithotomy. Ideally, a stent placement should be performed under fluoroscopic control and after proper pacification of the pelvic elevation system. We know that a double J stent is called double J because it has a J or a pigtail shaped coil at both ends that makes the stent self-retaining. After looking at the various company stents available in our operation theatre and after looking at various images of the DJ stent online, we realize that stents have coils which face in opposite direction. Based on this observation, we made a hypothesis that because there is a space in the bladder which is medial to the ureteric orifice and space in the kidney which is lateral to PU junction, pelvic junction, the bladder end of the stent should coil medially and the renal end should always coil in the opposite direction, which is laterally. The aim of the study was to investigate whether based on the direction of the coil of the stent, we could predict whether the stent was properly placed or not. Normally, an improper stent placement or an extrarenal stent placement is suspected when you end up deploying an extra length of the stent, when you see blood around or through the stent, or if the stent deployment becomes very, very difficult. Extrarenal stent placement is commonly happens in 4 situations. In patients who have upper tract infections, because the mucosa is edematous and friable, even hydrophilic glide wires can perforate outside the mucosa and go extrarenal. If by error you use the rigid hard end of the rigid rear end of the guide wire, this rigid end can perforate the pelvic elevation system and go out of the pelvic elevation system. If you use extra long stents, the extra length can perforate the calyx and go out of the pelvic elevation system. Or if you do not monitor the placement of the stent under fluoroscopy, you carry a risk of poorly placed stent. We prospectively evaluated all the patients who had retrograde stent placement from June 18 to May 2020. We excluded patients with malrotated or anomalous kidneys, patients with history of prior renal surgeries, or patients where stents were placed in antegrade fashion. Standard cystoscopic stent placement was done where initially hydrophilic glare was placed over which an open-ended ureteric catheter was placed. This was exchanged to a rigid wire or a zebra wire and over which the stent was deployed. A note was made of the length of the stent deployed. If undue pressure was needed for stent deployment, we noted the color of urine through the stent or by the side of stent, and we also noted where and how the stent renal end of the stent coiled, whether it was medial, lateral, or incomplete coiling. On-table ultrasonography was performed in all patients to document proper stent placement. Whenever there was doubt about stent position, either because of difficulty in deployment or because of blood or because of improper coiling, a retrograde pyelography was performed by the side of stent to look for stent position. If misplaced stent was confirmed, then the stent was repositioned in the pelvic elevation system under fluoroscopy. We know that the standard renal end of the coil should look like this, where a complete circle has been formed and the circle is facing laterally. In the first patient, at the end of ureteroscopy, when the stent was placed, the stent was coiled medially. Now, also this patient had blood by the side of stent in the bladder. A retrograde pyelography was performed by the side of stent to identify that the coil of stent had gone outside the upper calyx. Under fluoroscopy control, this stent could be repositioned in the pelvic elevation system, and once it was repositioned in the renal pelvis, it took a proper shape of a coil which was coiled laterally directed. Another patient, radiolucent PU junction stone, pre-RIRS stenting was attempted because patient had infection. The stent had a gradual coil which was coiled medially. RGP done by the side of stent confirmed the stent to be outside. Under fluoroscopy, stent was pulled down in the pelvic elevation system, and once it came in the renal pelvis, it had a beautiful coil which was laterally directed. Infected obstructive uropathy because of papillary necrosis, emergency stent was planned. The stent coil was medial. Also, there was blood by the side of the zebra wire. Hence, a retrograde pyelography was performed. The upper coil had gone outside the pelvic system. It was pulled down and repositioned. Once repositioned, it coiled laterally. This patient, the misplaced guide wire was identified. The guide wire had gone excessively inside and was coiled medially. A retrograde pyelography confirmed that the guide wire had gone outside, and hence proper stent position or stent placement was done in upper calyx. A total 282 patients were analyzed. Most patients had a smooth and uneventful stent placement. In 22 patients where we were not happy with stent placement, a retrograde pyelography was done. Proper deployment was confirmed in 17 patients, and all these patients had a laterally directed coil. 5 patients had a medially directed coil or an improper coil. RGP confirmed that the stent had perforated the upper calyx and had coiled outside the pelvic system. The stent could be repositioned in the pelvic system under fluoroscopic control. Our hypothesis that the medially directed coil of the renal end of the stent suggests improper stent placement held true in all these 5 patients where we found this abnormal orientation. This simple observation is based on 2 facts. Stent has coils in opposite direction at either end, and we have space in the kidney, that is renal, pelvis and upper calyx, which is lateral to the pelvic junction. Our hypothesis further gets an impetus by the fact that we looked at the coronal X-ray images published in various case reports about this complication of DJ stenting. Interestingly, all the images that were seen in the journals showed a coil which was medially directed. Thank you very much for a patient hearing.